Very good evening, one and all, and warm welcome. As we all know, CVD is the leading cause of death in India. Indians tend to have atherogenic dyslipidemia. High LDL cholesterol and high non-HDL cholesterol is present in half of population. Raised total cholesterol and triglycerides is present in more than one third of Indian population. Today being World Heart Day, we are here for an academic feast. With us, we have foremost experts in the field of cardiology. I have the honor and privilege to introduce them. For the first session on lipid lowering therapy in acute MI, Strike Early and Strike Strong, we have Professor Dr. Marco G. Menuni, sir, the author of Fast Note Study himself. Dr. Marco G. Menuni, sir, is a consultant cardiologist at Maggiore della Carita University Hospital Novara and researcher at the University of Eastern Piedmont. Sir has performed over 4,100 interventional cardiology procedures with expertise in coronary interventions, structural heart disease, valve therapies, and left atrial appendage closure. Sir is a recipient of the ESC EAPCI Fellowship Award and has been recognized in the Young Leadership Program. Sir has contributed to numerous international registries and trials and authored over 100 peer-reviewed publications including NEJM, Lancet, JACC, and European Heart Journal, and also International Journal of Cardiology. Sir has delivered regular oral presentations at international congresses and led clinical trials and being an principal investigator in multiple international registries and trials. We warmly welcome Sir. For the second talk, for the second important talk on overcoming statin hesitancy, a World Heart Day focus on patient adherence and education, we have Dr. Jamshed Dalal sir as an esteemed speaker. Sir has extensive 40 years of clinical experience in the field of interventional cardiology. Sir has been associated with several renowned international institutions, including National Heart Hospital London, Welsh National School of Medicine and University, Hospital of Wales, UK, Queen's University, and Kingston General Hospital, Canada. Since 1987, Dr. Dalal has helped to establish the cardiology departments and interventional cardiology programs in leading hospitals of Mumbai, including PD, Hinduja, Leelavati, and Wokhad hospitals. Sir is presently the Director of Cardiac Sciences at the Kokila Ben Dhirubhai Ambani Hospital, Mumbai, and has received multiple honors and awards, including CSI Prize for Distinction at DM Cardiology in 1977, the Young Researcher Workers Award by the British Cardiac Society in 1981, and has been awarded Fellow of the Royal College of Physicians, London in 2016. We are honored to have you and we warmly welcome you. And without further ado, I hand over the session to our first esteemed speaker, Dr. Marco Menoni, sir. Sir, over to you.
So here we go. Can you hear me and see me?
Yes, sir.
Yes.
Perfect.
Okay. So good evening, everybody. Thank you for this invitation. It's a great pleasure sharing with you our experience on lipid lowering therapy. I just want to keep this simple. 3 messages up front. First, after MI, the risk is front-loaded. Time matters. Second, stepwise lipid care is too slow for the early danger window just after the MI. And third, the upfront combination therapy gets more patients to target sooner and keeps them there. So if we agree on these 3 points, everything else is just an execution. So let's see all the rest now. And let's start from the scratch. So this slide shows the linear association between LDL levels and major adverse cardiac events. this is the backbone. The lower the LDL, the fewer events. If we look the line on the right, the yellow line, every 39 milligram deciliters drop the LDL cholesterol, reduce events significantly. And the absolute benefit is bigger in the yellow line, which represents the secondary prevention. So this evidence is has been included during the last European Society of Cardiology guideline recommendation for the management of ACS and dyslipidemias. In 2019, ESC guidelines reduced the LDL target from 70 milligrams deciliter to 55 milligram deciliter, but the traditional stepwise path start high intensity statin, recheck in a couple of months, then maybe add the ezetimibe, then maybe add the PCSK9 inhibitor, creates a timing problem. These 3 months, this is the algorithm proposed by these guidelines. And this, as you can see, there are 2-3 months checking, and those 2-3 months between step look reasonable on the paper, but in the real life, they cost events, because the early post-ACS window is where the risk clusters. So we need to keep the destination, very low LDL cholesterol level, and change the journey faster and fewer steps as much as possible. And this is exactly what, when I'm talking about the early window, these slides represent the early danger zone after ACS. So this is a retrospective data from the Swedish National Registry, including more than 1,000 patients, 100,000 patients admitted for MI. And as you can see, about 10%, one patient out of 10 of these patients experience a recurrent MI, stroke, or cardiovascular death within the first 100 days after the initial ACS. So in this zone, we have a very special and important window. And so then we have an effect of age. If we stratify for aging, you can see 80 older people are very high risk. Of course, we cannot act, we cannot control age, but we can control the LDL cholesterol and speed up the LDL cholesterol lowering. So our goal is not just to the target, but is to get the target fast. And this is what happened in Europe. So this is the pretty much contemporary registry survey we performed in Europe. And in this slide, we try to understand why a stepwise underperforms in real world. So when you look at the real life cohorts, this is a survey. You see more than 1,000 patients included in this European survey. And when you look at these real life cohorts, the percentage of post-ACS patient at the LDL goal with a stepwise approach stays low across all the follow-ups time points. So there is no changes in follow-ups time points. You see, you can get 18% of the target at the first follow-up, 34, and then between the second and the first, you cannot achieve any further benefit. And this is reflected also in terms of prescription or discharge. As you can see, there is a flat number of percentage of high potency therapy prescription between the first, the second, and the third follow-up. And this is what happened in real world. So there are no changes in the percentage of patients at the LDL over the different time point, corresponding with no changes of therapy over time. And this is another registry. This is in Italian. We participate in this contemporary registry. This is a registry study which included, we collected 1,000 patients with ACS from 35 Italian hospitals. And as you can see here, and again, this is data confirmed the European. So there is no change between the discharge, the first months and the third months. Actually, it is interesting. As you can see, there is about 50% of the patient discharged with statin and ezetimibe, so the double therapy approach at discharge, and we have almost the same number at 1 month and 3 months follow-up. So the situation in Italy is pretty much the same. And what happened to the LDL target? As you can see, about almost half of the patient can reach the target at 1 month, and this target doesn't change over time. So this is a confirmation of the European trend, where we are not performing so well in terms of targeting the LDL value in ACS patients. So which are the predictors? We try to ask to these data, which is the predictors of achieving LDL target at 1 month. So the predictor is basically the intensity of therapy, the statin intensity, the statin monotherapy at discharge, the presence of ezetimibe and the statin, so the double therapy and the triple therapy. All these more potent strategy were associated to gain the goal. So now let's go further. So why we need to strike early, strike strong approach? This is the physiopathological based rationale. So we have a strong evidence that if we push intensive lipid lowering right away after MI, there is a strong evidence that you can stabilize the plaque, the coronary plaque. This study presenting these slides demonstrate how using by the use of OCT is very precise coronary imaging, show a meaningful changes in just 3 months. Long-term data from 2 big randomized trials like IGENS and Pacman MI, but confirm this signal presented by Liano. And how does intensive therapy make plaque safer? First, less lipid inside the plaque, because we size the content of the plaque, as you see in these figures. So the lipid arc of the plaque is reduced by a significant amount. A smaller amount of lipid means less vulnerable plaques, fewer macrophages, less local inflammation, and lower rupture or thrombosis risk. And then we can generate a thicker fibrous cap, so more resistance to rupture. Then we have at the end of all these process, we have a slower atherosclerosis progression, so more longer term stability and better outcomes. So what is the practical takeaway today? Starting high intensity statin immediately, add ezetimibe if the target would be met, and consider even early PCSK9 inhibition in appropriate patient, or not just to moving a lab number. We are changing the biology of the plaque within weeks in our patient. So let's see which are the data, the clinical data, which confirm this biological phenomena. So clinically, it's the same logic we use elsewhere. When the baseline gap to the goal is large and the risk is high, we start the combination therapy upfront right away. Lipid deserve the same playbook. So in this meta-analysis, we try to collect all the contemporary evidence from randomized control trial. We collect 10 randomized control trial looking at the safety and efficacy of very low LDL cholesterol, meaning less than 40 milligrams deciliter, and we meta-analyze the efficacy and the safety. And what we have found that if you go low, you can get less MACE. So we have a protection in terms of major adverse cardiovascular events. And what happened in terms of all the concerns that a lot of colleagues have about lowering so much the LDL. So we have no difference in cardiovascular death, in non-cardiovascular death, no difference in adverse events, no difference in drug discontinuation, no difference in cancer, no difference in stroke, diabetes, neurocognitive disorders, and hepatobiliary disorders or muscle disorders. So there is a very huge confirmation of very safe profile of this approach from these 100,000 patients. So putting all these together, so these slides, I took these slides from the ES guidelines, and what these slides show? The slides show what each drug buys you. So which is the average of LDL reduction with a different strategy. This is just maths. So we need to make some calculation, and we can translate these slides to the bedside. So for example, high intensity statins like rosuvastatin 20 or 40 milligrams expect a 50% LDL reduction with a good adherence. Remember then the rule of 6, doubling the dose adds only 6% more. So when you are close but not there, add the second agent. Not just don't double the dose. Ezetimibe 10 milligrams add another 20% on top of statin. And if you dubbed the statin alone, will land you under 55%. Then starting ezetimibe on the day 0. Then you have PCSK9 inhibitors like alirocumab, volocumab. You have 60% more reduction on top of statin and ezetimibe with a very rapid onset. So what we have done in our center, basically we built an algorithm in order to personalize the therapy, the lipid lowering therapy after an admission for acute myocardial infarction. And this is our lipid lower therapy approach. We call this approach strike early and strike strong, SES, in a myocardial infarction. So here we introduce the SES algorithm. The idea is very simple. So you can decide the intensity at the bedside based on a baseline LDL, prior statin use, and the percentage of reduction needed to reach the 55 milligrams deciliter. So if a patient is statin naive with the LDL less than 150 milligrams, then you start a potent high-dose statin, add the ezetimibe when the distance to the goal is more than 50%. If the LDL is more than 100%, go directly to the triple therapy, statin, ezetimibe, and PCSK9, because you need at least 85% of reduction. So if you have this is the right part of this algorithm. If you look the left part, so for patient already on statins, then in this case your number is 100 milligrams deciliter. So if your LDL is less than 100 milligrams deciliter, then step straight to the ezetimibe and PCSK9. I'm sorry. then you just increase the statin dose or change to a more potent statin or add ezetimibe. Then if you have more than 100 milligrams deciliter, then you have to go to the triple. So add ezetimibe and PCSK9 on top of your statin. See, this is what we act so far in our center. And in this paper, we try to describe this attitude, and based on this protocol, we collected the data from a registry in order to compare outcomes across the 3 management periods. So we just compare the 3 periods. The period A. So this is the this is the slide. The slide is the frame of the study. The name of the study is a FAST note, which is an observational study. It's a single center, including 500 consecutive patients with acute myocardial infarction treated with PCI and analyzed in the 3 to 6 months eras. So the period A, the first one, is the 2019. We used, at that time, we used the 2016 ESC guidelines with a goal of the LDL less than 70 milligrams deciliter with a stepwise strategy. Then you have the period B, the yellow one. The period B is 2021, when we achieved the guidelines, the new guidelines of ESC that lowered the goal at 55 milligrams deciliters, but still with a stepwise approach. And then we have the contemporary period, what we are doing so far. So the period C, and where the target is less than 55%, but we personalized and we used the strike early and strong lipid lowering strategy. So the primary endpoint of the study, we have the laboratory endpoints, which was the proportion reaching guideline LDL goals at the follow-up 1 and 3 months. And then we have a the second primary clinical endpoint, 1 year MACE in terms of cardiovascular death, myocardial infarction, and stroke and unplanned revascularization. Let's see the results of this study. So with the which was the lipid lowering therapy at discharge, with the strike early and stronger, discharge prescription changed meaningfully. As you can see, the green bars, there is a big changes in terms of ezetimibe prescription, in terms of more potent prescription. Almost all patients were on this potent statin. Then we more than doubled the association of potent statin and ezetimibe, and we prescribe a lot, 33% of patients, 1 out of 5 patients were discharged by the hospital on PCSK9 inhibitors. So this show how a simple rule-based bedside algorithm can translate into immediate appropriate intensification in the real world. And let's see what happened to the goal, to the LDL levels and the goals attainment at the follow-up. Biology followed prescription. So LDL cholesterol fell most between discharge and the first visit with strike early and strong was a 60% reduction versus 40% in the early periods, and the median LDL cholesterol at the first visit was 41 milligrams deciliter. So goal attainment improved markedly at the first visit. 83% reached less than 55 milligrams deciliters with SES versus 55 and 39 before. And these numbers confirm the European and Italian trend, which were stable between the first and the second follow-up visit. So, in other words, more patients got to the goal and stayed there. This is exactly what early and appropriate combination therapy is supposed to do. If we look at the LDL levels and the goal attainment at the follow-up, we look in this slide the predictors of reaching LDL targets. So this is very interesting multivariate analysis, because of course this was expected that if you personalize and you go strong with your therapy, you will reach the LDL target. But it's interesting, as you can see, that the use of PCSK9, but to me this is very interesting. So the non-potent statin at discharge, so like the old statins, the old molecules of statins, they were associated to in a negative way to reach the goal, as well as the baseline. So as most far as you are from the goal, your chance to get the goal became is smaller. So let's see the clinical outcomes now from the FAST node registry. So these are the the Kaplan-Meier estimates of major adverse cardiac events in terms of cardiovascular deaths, myocardial infarction, stroke, and revascularization. So the clinical signal aligned with the biology. Again, 1 year MACE was similar in the two stepwise areas, so 12 and 11 at 1 year, but dropped to 3% with strike early and strong. So the global log rank test, the statistic was significant, and the strike early and strong remained independently associated. If you look at the multivariable analysis on the right, with lower MACE after adjustment. So let's we ask further question to our data, and this question is if there is a clinical if the clinical outcomes according to timing of LDL target reaching may have an impact. So patient who hit less than 55 milligrams deciliter early and sustain it across both visits at the lowest event rates, so less than 4%. If the target was reached only early but not remain, even was higher, 9%. If the target was reached late or never, events were the highest, so 13%. So early and sustained control carry an adjusted HR of 0.42, while late or never control carry an adjusted HR of 1.97 versus the reference. So two additional takes away from this. The share of patients achieving both the absolute goal and more than 50% relative reduction was much more greater with the strike early and strong approach, and that combined absolute and relative success identify a particularly low risk group. This is a practical message that you can see here in this last analysis we ran on this data. So the question is here, as you can see in the guideline, the goal is not just the absolute number, like less than 55%, but also the reduction of more than 50% from the absolute baseline. So in this analysis on the right, you can see that if you have both, so less than 55 and more than 50%, you'll be the best clinical outcome. If you are one of two, you will be in the middle. If you are known of the two goals, you'll be the worst. More than 40% of MACE at 1 month, 1 year, sorry. So I'm approaching the conclusion of this talk, and I put in this slide the new recommendation, which is very recent from Madrid, the ESC in Madrid, where the new focus on dyslipidemia was published by the European community. And as you see in this recommendation, the two target matters, and they are complementary, of course, and intensification of lipid lower therapy during the index ACS hospitalization is recommended for patients who were on any lipid lowering therapy before admission in order to further lower the LDL level. So basically the guidelines was taking account of all this evidence that I was talking, and included all this evidence in the ESC recommendation. So this is my conclusion. The lower is the better. This was the our history for the LDL cholesterol level for patients with the ACS should be amended as the lower, the early, and the longer are the better. So thank you for attention, and I'm of course open to your question.
Thank you, sir, for your session. So we will have a Q&A after Dr. Jamshed Dalas's session. So over to you now.
May I share my slides, please?
Yes, sir.
Yeah. Right. I hope you can see them.
Yes, sir. Perfect.
So, wonderful talk, Professor Marco. Indeed, the problem is that the data is so consistent about the use of drugs early and fast, and yet the problem, and particularly so with statins, remains an issue of statin hesitancy. I don't think there's any drug in the history of cardiology which has so much anti-feeling about it. And this has been there for years. I've had patients come to me with books saying life without statins, and the amount of negativity that is associated with statins creates a lot of statin hesitancy. Now, quickly to mention the burden of dyslipidemia, it's extremely high, particularly in our country. In India, unfortunately, we have heart disease at a very young age. We have hyperlipidemia at a much earlier age. And we also got a very high burden of hypertension and diabetes. So really, we are struck with the problem of early coronary artery disease associated with a high incidence of diabetes, blood pressure, and hyperlipidemia. So if anything, we need to be even more careful than what Professor mentioned, because as you can see from some of these ICMR studies, that the reported incidence of high LDL and high triglycerides is almost 50% or more. Now, we also know that statins are the cornerstone of ASCS. As mentioned earlier in the previous study, most of the time statin remains the primary drug. Yes, you can add ezetimibe. Yes, you can use evolocumab, but statins still remain the number one choice for majority of patients to control their LDL cholesterols. We know, and has been extremely well explained, reducing statins stabilizes and regresses atherosclerotic plaque. I'm, of course, very impressed by the IVUS and the OCT data, which clearly shows that when you bring the LDL cholesterol down, you actually get plaque regression, stabilization of the plaque, thickening of the fibrous cap. And clearly that is a very, very strong evidence of the extreme benefits that you get with reduction of LDL. And that, of course, manifest in so much of the clinical output benefits and the significant reduction of cardiovascular events and all-cause mortality. But unfortunately, in spite of that, we never seem to reach the goals. Now, if you look at what happens if you discontinue, so discontinue has a price to pay. So patients who do not take statins, either because of statin intolerance, which I think is probably not the right word, it's probably statin hesitancy rather than intolerance. And if you discontinue statins or any LDL therapy, then you get an increased 32% when you do it for primary prevention and 28% in secondary. So clearly, there's a big uh, uh, event rate increase if you do not take drugs to reduce your LDL cholesterol. Now, there are various definitions of statin intolerance: inability to tolerate a statin dose significant to reduce CV risk, any adverse effect that reduces the quality of life and leads to discontinuation of an otherwise beneficial drug, or inability to tolerate two different types of statins at any dose, or not able to escalate the dose, and it's not attributable to drug interactions or comorbid conditions. So in simple words, adverse effects associated with statin therapy, not changing with treatment dosaging, and reduction in dose or discontinuation. And there are two types of intolerance. One is complete intolerance, where the inability to tolerate any statin of any type, and otherwise is the partial intolerance, where patient may be able to tolerate a small dose or tolerate a certain type of statin, but insufficient to lead to LDL goals. So clearly you need to do at least two different types of statins and take at least the lowest approved dose to see if statin intolerance actually exists. Of course, various countries and various meta-analyses have been there, and the statin intolerance varies from 10 to 20%. And of course, the most common one, as you all know, is muscle symptoms, because that's been drilled into our minds by non-medical people that statins produces a lot of muscle problems. I'd like to introduce here the subject of nocebo. I think you're very aware of nocebo effect, and Samson trial was one of the many trials which showed that. So in Samson trial, they did a double-blind trial. Patients didn't know whether they were taking statins or they were taking placebo. But those who knew that they were taking statins, they had a much significant muscle problems. And when they were discontinued, many of them continued to have intolerance in spite of the fact that they were taking placebo. And then they were switched over to statins, and many of them could tolerate statins well. So clearly the nocebo effect, that means once you know that you're going to get a side effect from a particular medicine, then your chances of getting that side effects are very high. I know, for example, when you prescribe for some other drug to a patient for which patient is not aware what the drug is, they often get much less side effects than when they take common drugs for which the side effects have been so much spoken about in general public. Of course, the most common related manifestations of intolerance are muscle pains. And again, they may again differ from mild aches to very severe myopathies, and we need to keep that in mind. And the prevalence of muscle symptoms may be as high as about 30%. But I think it's important that we remember that statin-associated muscle symptoms, STAMs. If it's a myalgia, this is very common. You get muscle aches and pains. Then you get myopathy, where the muscle symptoms are there with a raised CPK, but less than 10 times the upper limit of normal. So I think this one is probably a lot of nocebo effect. This one you have to be a little watchful and see what happens further. But then you do, in very rare occasions, have rhabdomyolysis and autoimmune myopathy. So muscle symptoms associated with more than 10 times CK or other evidence of antibodies, etc. So in these two situations, it is a problem, and I would not continue statins and would not restart statins. These are the situations which actually form the majority of problems, and that's where we need to fight the statin intolerance. Now, we all know that all muscle complaints are not statin induced. We know muscle aches and pains are very common in everybody as you get older. Often patients mistake muscle for joint pains. All of us have had patients who have knee pain because of arthritis, and they stop statins because they think knee pain is associated. So clearly, it's not joint pains that are associated with muscle intolerance, with statin intolerance. And many patients tolerate statins if you give them lower dosage, if you give them alternative statins, or if you give longer dosing intervals. So there are various ways in which you can manage the statin intolerance. So you have to see also the patient's statin. You have to discover whether the patient is intolerant genuinely or is just hesitant because of all the factors that I mentioned. So please check if the muscle pains or complaints started after initiating statins. Did they stop after stopping statins? Did they recur on starting statins? I think if you prove that, it would probably be more effective. But in spite of that, as long as the patient knows they're on statins, the nocebo effect will, of course, come into picture. And we need to keep that in mind. We need to, before saying that the patient is just hesitating without any reason, we need to make sure, we need to measure CPK, check liver enzymes, thyroid function, vitamin D, rule out alternative causes of symptoms. You can try a different statin at a different dose or lower the dose of the original statin. And more important, communicate with the patient. What is the patient worried about? Is he really just hesitant or is he truly intolerant? And I think that's important. So I'll go back to that, that communication is a very, very important part of managing statin intolerance and hesitancy. So as I mentioned, you can switch the statins. We got many varieties of statins, and some people tolerate one versus others. Some are lipophilic, as you know, some are non-lipophilic, some are less strong, some are milder, and therefore modifying the dose is another thing. Reduction of dose often produces a reduction of symptoms, and dosing at different intervals instead of giving every day, alternate days, twice a week or 3 times a week has also been one of the ways to manage the statin intolerance. And of course, as mentioned again and again, combination therapy. Professor Marco mentioned about uh, combining it with ezetimibe. And it's a pity that many physicians and cardiologists don't use ezetimibe as frequently as it should be. It's a very cheap, easy drug, mostly acts in the GI tract, very minimal symptoms, and can give you a further 20% reduction of LDL. So, in my opinion, I think you should always give statins along with ezetimibe and get a benefit of the ezetimibe. Fortunately, in India, we have combination pills of a statin with ezetimibe in various dosages. And I think that single pill combination, just like in blood pressure, single pill, multiple drug combinations is the most effective way to get to your guideline mediated LDL levels and also to improve compliance. So if you see most patients actually intolerance is not really intolerance, probably less than 5% are genuinely intolerant to therapy. Now, once you found out that the patient is having symptoms related to and wants to stop the statins, I think we need to reassess the cardiovascular disease. Has the patient already had an infarct? Is he at a 25% risk of future events? Or is he a very low risk patient? That's important because then you have to decide how much to pressure the patient into taking the drugs or to give a non-statin drug. So you need to regard about therapy and the use of non-statin drugs. We need to educate the patient on the percentage chance of this. People often read side effects. We know side effects occur, but they often think that the side effects are very common. We need to reassure them that it's the minimal number of patients who actually have then also very important, they need to be informed about the cardiovascular cost of not taking therapy. Most patients underestimate that risk, and very important that patients think the chances of getting a heart attack or a stroke are very minimal. They usually underestimate. We have patients who have got diabetes, hypertension, strong family history, and you ask them, do you think you're going to get a heart attack? Oh, may not get. I'm very healthy. I do this. I don't eat non-vegetarian food, etc., etc. And I think that's where sometimes CT angio has been useful because when these same patients who underestimate their risk and do not want to take therapy, when they have a CT angiography and it shows all the 30, 40, 50% plaques all over their arteries, they suddenly realize they have a problem and they become much more open-minded about taking therapy. And of course, we mustn't forget, we don't mention it again and again, but we mustn't forget that lifestyle, diet, exercise, weight loss, etc., forms primary part of your treatment, whatever the type of statin, non-statin, or other therapies you use. So if statin is indicated despite prior symptoms, the best thing is to start at a low dose and then gradually titrate opposite. Now, again, Professor mentioned about the importance of early and rapid management in ACS. When I'm talking of low dose with gradual increase, I'm not talking of patients with ACS. I'm talking of the general introduction of statins in patients who are statin hesitant. So please do not think that I'm suggesting low dose and gradual titration in patients with acute coronary syndromes. There, as Professor mentioned, rapid, important, early is very, very important. And then again, as I mentioned, consider starting at the lowest dose, alternate day or twice weekly dosing. And then if you want to change the therapy, you want to retest the patient, maybe give about a 4-week washout period before you start the next. Now, these are the guidelines. Professor Soni was the principal investigator, presenter, CSI clinical practice guidelines on management. Here you have a patient with statin-induced myocardial symptoms. If there are symptoms, but the CPK is not very high, little bit elevated, you can stop the statin for a couple of weeks, reassess the symptoms, and of course, restart statins, maybe another dose or some. Clearly, it's important that patient psychology needs to be kept in mind. If you give a statin to the patient and patient is not taking it because of whatever reason, just pressuring this patient to keep taking the same dose and the same drug is probably not going to work. So you need to make some changes before the patient accepts. Of course, if the patient gets a rhabdomyolysis, then no statin to be given again, and you have to use non-statin lowering drugs. For the majority of patients, symptoms with CPK, which is elevated, again, you stop statins for a while. If the CPK becomes normal, statins resolve, a different statin, smaller dose, maybe a couple of times a week, and then gradually build up. And then, of course, if the LDL goals are not achieved, then you have to use statin therapy. So this is a management of chronic management of patients who have high risk problems. Again, this is not the way to treat patients with acute coronary syndromes. A poor adherence to statin therapy, multiple reasons. As you know, the social media exaggeration of statin-induced muscle. All the time you read about statins. You even speak to doctors that doctors themselves are concerned about statins. Very few doctors take statins. They take very small doses of statins. So doctors themselves are not quite, and I mean by doctors, even cardiologists, are not too attuned to bringing their own LDLs down. And I think that's probably the reason. I think no doctor will have his blood pressure high and don't worry about it. No doctor will have his sugars high and not worry about it. But they'll be a little less worried about lipids than they would be. So that seems to be less anxiety about a high lipid than there is an anxiety about high blood pressure or high sugar. And of course, a patient can manifest in multiple ways, as I said, just simple symptoms, but it can produce significant problems in terms of important physical disease. They're also concerned a lot about liver disease and memory loss. Let's go into that. This is a prospective study looking at what people worry about. So if you look at the worry, the majority of people, 27% worry about the side effects. Other people, 26% want to try diet and exercise. And we've all heard that before, that, oh, doctor, I'll cut down my diet, I'll exercise. But you know very well that LDL predominantly is internally produced, and diet and exercise has a very marginal benefit on these patients unless they're grossly obese or they have some major problem. But otherwise, diet and exercise, of course, remain important, but are not going to be the cornerstone of managing these patients. Then many people want to take other things, all sorts of supplements which have been promoted and propagated for benefit for long life and for lipids. We know that most of these usually don't work in terms of reduction of LDL cholesterol, but yet patients wish to try them first. Some of them don't believe that they need it, they don't understand the risk, and therefore they want more tests to be done. And there are, of course, all sorts of other reasons. But the major reason remains worry of side effects and want to try diet, exercise, and supplements before they start statins. And the most common cause of worry, as I mentioned, is side effects. And the next is the wanting more additional tests before they want to start statins. So we look at some of the more detailed investigation studies in the trial. It showed that what are the patients genuinely worried about. Now, I think it's important to know this because, as I mentioned, if you want a patient to overcome the statin hesitancy, then I think communication is very important. As you can see, the majority of patients are worried about liver damage. So many people in India also they're worried about kidney damage. So when you give a patient a statin, his first case is, will it damage my kidneys? Will it damage my liver? And then, of course, a lot of talk about memory. So the third question, of course, is do I get memory loss? Not many patients know that high-dose statins can increase diabetes, but that remains a factor, and I think that should be always kept in mind in a patient who's very prone to getting diabetes or already in a pre-diabetic situation, that may occur. But the patient's concerns are more about liver damage and memory as a main cause. The muscle pains are a problem, they know that, but they're concerned about damage to the liver and damage to their memory. So if we look at more data, about 60 to 70% of patients would take statin if it lowered their 10-year risk. So it's up to us to explain to them what their risk is. So this requires various charts to show them their cardiovascular risk because they underestimate the risk. So we have to show to them their 10-year risk. 64% will start if the doctor said it was crucial. If the doctor wavers about it, yes, you may take it, you may do it, yeah, LDL is not too bad, then of course the patient is not going to be very aggressive. And of course, a very large number of patients take after heart attack and stroke, and we all know that very well. The best way to make the patient take a statin is for him to get a heart attack or a stroke. And we also know that history of cardiovascular disease are more likely to initiate. So once a patient has coronary artery disease, is known to have coronary artery disease, shown on a CT scan, or shown on an angiography or already has a myocardial infarction or stroke, he's much more likely to take drugs than he's not going to. So the greater hesitancy is, of course, in primary prevention, because there the patient is asymptomatic. You're trying to convince the patient to take a long-term, lifelong medicine for something which he thinks is very low risk for him and for which he has no symptoms. So obviously hesitancy is going to be maximum in primary prevention. There's a lower threshold acceptance in secondary. Once you've got coronary artery disease, it's clearly more easy to start the treatment. So really, risk communication is very important for primary prevention of patients. As Professor said, if you get a myocardial infarction, yes, it's very easy to convince the patient. And as you can see, a large number of them will take statins. When you talk of adherence and compliance, there's a subtle difference between adherence and compliance. Adherence is a partnership between the doctor and patient. The patient co-informs the patient and provide a recommendation respecting to timing, frequency, at risk. So this is what we should try and do. Communicate with the patient, explain to them and make the patient a partner. So the patient should monitor the lipids, patient should understand the significance of taking it, patients should accept the dosage, the timing, the frequency. Compliance is one way. You have to take it, otherwise don't come and see me again. That's not really the way that you're going to overcome hesitancy. When you talk of adherence, you also have three different initiation. So the important part is the initiation of statins. Most patients will not start statins even if you tell them. So initiation is an important part. Then implementation. You start it, but the patient stops it in between for whatever reason. So great number of patients start the treatment, but they'll drop off the treatment or cut down the dose. And some of them will completely discontinue your treatment at some point in time. And so non-persistence is one of the commonest cause of poor adherence. Now, how can you measure adherence? How would you know that your patient is taking statin or not? Well, from the LDL point of view, it is a little bit easy because you can monitor the LDL, and if the LDL is down, well, patient is taking the drugs and LDL goes up. Many times you ask the patient, are you taking your statins? And he says, oh, yes, I'm taking. But you look at the LDL value, it was 60, now it's gone to 110. And you smile and tell the patient, I can make out you're not taking. I says, yes, doctor, sometimes I miss. So you know how that behaves. But there are various ways. You can do interview, questionnaires, pill counts, electronic monitoring. You can give digital medicine where you can actually monitor every single part of it. But again, some of these are difficult and expensive, and these are not very accurate as well. Pill count, patient can just throw away the pills and come to you with an empty box. So the important factor in adherence and management of adherence and compliance is patient's experience. And I think that's important. The patient may have a relative who's had severe problems with statins. You have to know that factor. That's what might be putting the patient off. So clearly patient's experience. Patients say, I took the tablet, I had this problem. Patient's attitude. Some people just don't believe in drug therapies. And therefore you have to more convincing needed for those patients. Then barriers in health system. Cost of the drug. Never forget the cost of the drug. When you're giving a drug for lifelong therapy, cost becomes extremely important because you're talking. So this really is important. Rural areas assessment, the access to hospitals, the availability of drugs is also very important. Fortunately for us in India, cost is not a major problem because of the generic brands and the multiple brands which are available. Still, if you look at some of the brands of rosuvastatin, etc., they're not that cheap as well compared to the fact that you have to take them every day for the rest of your life. But probably the most important factor is the professional, the healthcare professional. The relationship between the doctor has emerged as the most important factor for adherence to medicines. Some people are empathetic, communicative, and pleasant. The others are criticizing. So a patient's not taking statins for whatever reason, he's hesitant, he's worried about his liver or his memory, to just tell him, no, you're wrong, you don't understand, you have to take it, otherwise you're going to have a heart attack. That's not the way. You're going to explain to them why it's important, what are the chances of getting future problems, how low are the side effects. So it does take time. It requires certain graphs and charts and things to understand and explain to the patient, and then start with a small dose so that the patient gradually builds a reputation. So again, as I mentioned, there are various ways in which you can measure. These are non-invasive and these are invasive. Again, we can measure blood levels and urine levels, but you all know people bring somebody else's urine for markers. So people try and fool you even when they're not taking drugs. The other thing I think we should not forget when we talk of adherence and compliance is that the patient is not just taking one drug, the statin, especially a cardiovascular patient. As I mentioned, half of them have got diabetes and blood pressure. So they'll be taking antihypertensive drugs. they'll be taking other cardiovascular drugs, they'll be taking aspirin, diabetic drugs. And again, the patient's adherence is different for different drugs. So it's not that a single patient is non-adherent for everything. There are some patients who don't want to take anything, but there are certain patients who will take certain things but not take certain things because that's what's in their mind. For example, they take aspirin because it's not very well known to the world that aspirin produces bleeding. So they think aspirin is useful because we have been pushing that for decades, that aspirin prevents heart disease. So you can see far larger patients take aspirin. Diabetic medicines, as I always mention, more people will take diabetic medicines because sugar triggers often anxiety, but much less patients will take statins because they don't think it's that important. So within the spectrum of adherence also, there's a difference of adherence to different drugs. So clearly improving adherence and compliance is a complex problem. It requires reduction of pill burden, patient information and education, patient counseling, shared decision making, extremely important. And again, after having done that, you have to do dose dispense medication so the patient gets the dose at a less cost, reminders to the patient. So again, very important, and various other therapies, other methods, apps and various things to remind the patient of taking the medicines. So lots can be done. Should you be concerned about statin hesitancy? Of course we will. Clearly, we know that patients who don't take statins are a problem. Professor's also shown us so much data, but just quickly to go through this Brigham integrated study, adults with diabetes, no existing pre-existing coronary artery disease, and in decline or did not start statin therapy, there was significantly higher in cardiovascular outcome. As you can see, the risk is much higher. Myocardial infarction risk is higher and ischemic stroke is higher. I think when we talk of patients with statins, don't forget, we don't only talk of heart disease. I think it's important to remember that stroke is also an important factor. Stroke worries patients a lot as well. So not just talk of heart disease, but lowering statin also reduces stroke and other cardiovascular problems like peripheral vascular disease, amputations, etc. So everything is reduced, and I think we need to explain to the patient that it's a vast benefit that they get in taking statin therapy. So delayed statin therapy in patient diabetes resulted in a significantly increased cardiovascular risk, and this is explained by the greater LDL exposure over time. We all know we talk about LDL exposure time. So quicker and earlier we start in a chronic patient. Again, I'm not talking of ACS. In a patient, we start earlier LDL. The longer the low LDL, the better the patient for the future. So a patient has high LDL at the age of 30, and you start at 30, outcome will be much better when he reaches 60 or 70. If you wait till 40 or 50 before starting statin therapy, the effects will not be as important. So importance of timely statin initiation, very important, and I measured shared decision as very important. So you can do shared decision by taking risk calculators. So you need to have a risk calculator for a particular patient, looking at his age, diabetes, family history, etc. Also look at alternative strategy dosages. As I mentioned, if a patient is definitely not going to take statins, think of alternative strategies. Again, regular follow-up and reminders are very important. Once the patient understands the long-term benefits and receives a structured support, adherence improves significantly. So forgetfulness and lack of symptom perception are major barriers. Use visual tools and other methods to improve patient compliance. So friends, I'll end by saying that the medications reduce cardiovascular events. There's no doubt about that. Primary non-adherence is a big problem. Half of these patients do not inform that they're non-adherent. Remember, when you tell a patient, are you adherent or not, they're not going to tell you, no, I'm not taking the drug. They usually try and avoid accepting that. Patient educated and follow-up decisions are important. Don't forget the nocebo effect. And if LDL goals are not met, look into it as to why they're not met and treat it accordingly. Thank you very much, indeed.
Thank you so much, sir, for that wonderful session. Dr. Jamshed Dalal, sir, I have shared two questions right now with you in the chat box. So requesting you to take it and also, involve Dr. Marco Menuni, sir. And there are a few questions which I'll be sharing in the chat box with you, sir. I hope that's fine.
Yeah.
Yeah, I can see one question out here saying, is there a difference between atorvastatin and rosuvastatin? I mean, there are little differences between atorvastatin and rosuvastatin. But again, as I mentioned, you can start any of the two statins, and the patient doesn't tolerate a particular statin. Rather than forcing the patient to continue, one could easily change over the statin to another statin. And I think a gentle sort of telling the patient that this statin is less likely to produce side effects may in fact work for the patient, because the patient doesn't really know the comparison of different statins. So you could actually use a little manipulation also to say, oh, you're getting problems with this particular statin, let me change you. There are some genuine differences between atorvastatin and rosuvastatin in terms of lipid entry, etc. But I think statins, more or less, both will produce muscle discomfort in these patients.
Dr. Marco Menoni, sir, your opinion on this?
Yeah, of course. Can you hear me?
Yes.
I mean, rosuvastatin, atorvastatin, they can be exchangeable molecules. You can play with both. Actually, we prefer starting with rosuvastatin, and to avoid to get the maximum dosage, and we prefer to add the second molecules like ezetimibe. In case of side effect of supposed side effects, as you say, side effects often are not a real side effects, so is a real problem. But in that case, you can step back a little bit dosage and add the second molecules, and this kind of a trick is often a good one, because the patient feels less toxic effects of the molecules. So there is a lot of subjective feeling to when you reduce the dose.
Thank you so much, sir. Next question is from Dr. Shah, who asks about the role of moderate intensity statin and ezetimibe combination in those intolerant to high intensity statins. What are recent evidences and clinical implications? So, Dr. Marco Menoni, sir, would you like to take this first?
Yeah, I mean, this is the way to go. The way to go is to reach the goal. This is your purpose. So if you can reach the goal by high dose statin, please go ahead. But when you prescribe high dose statin, you can handle, you can face the risk of side effects. So by adding the second molecule to statin, you reduce the side effects, and at the same time you can reach the LDL goal. So it's more the effectiveness is pretty much the same, but you will gain with less side effect.
I think you should go the same way as we go for hypertension therapy. We know clearly now that instead of pushing one drug to more and more doses and getting side effects, multiple drugs in small doses, especially if given as a single tablet, because I think when we talk of adherence, giving multiple tablets is not going to increase adherence. Unfortunately, as I mentioned, in India, maybe unlike other countries, India has combination of statins, various, both rosuvastatin, atorvastatin, in various doses with ezetimibe. So you get 10 milligrams, 20 milligrams atorva plus rosuvastatin with ezetimibe. So that's a wonderful combination. If a patient doesn't want to, or you don't want to give 20 or 40 milligrams of rosuvastatin, use it 10 milligrams with ezetimibe. It'll give you as good a benefit as 20 with much less side effects. Comes as a single pill, so compliance will be maintained. So I personally feel that combination of ezetimibe with a statin is a wonderful combination.
Thank you so much, sir. Thank you for that valuable insights. So next question is from Dr. Pooja, who asks about inclisiran. So what is the clinical placement and who should receive, and what should be the line of treatment in current era? Dr. Jamshed Dalal, sir, would you like to take this first?
Well, the question of evolocumab versus inclisiran. Now we all know that the big problem of both the drugs is cost. So that remains a number one problem with inclisiran and evolocumab, and the fact that they're injectable. So there are two major problems. Evolocumab has the advantage that it has been used for a very long time. We have the OLA study, which is almost an 8-year study, and we know it's very safe. Professor Marco showed a slide of safety of low LDL. I'm surprised at how many cardiologists are still concerned about low LDL having problems. I have many cardiology friends who say, oh, I don't like LDL of 30 or 40 because it produces problems. But clearly studies have shown again and again, Dr. Marco showed beautifully the whole slide, looking at every possible side effect. there's really no increased problems of LDL of 30. And we know the benefits of LDL of 30. So clearly the use of evolocumab to bring the LDL levels down to that of significant benefit. I also think that evolocumab is much more useful in acute coronary syndromes because it acts faster. So if a patient has an acute myocardial infarction and you want to give a PCSK9, then please use evolocumab to start off with because the action is quicker. We also know that evolocumab has anti-inflammatory and other properties which are also very important with patients with ACS. We also know that in India, when a patient presents with ACS, he's got multiple other plaques in other arteries as well, which are important things to treat. That's not the stent in the artery with the infarct, but the other lesions that need treatment. In my opinion, I would think that I would like to, I know that we all can't do it and it may not be practical, but I'd like to give one shot of evolocumab on the same day as the angioplasty is done. Then you have a time to decide what you want to do, what LDL values are. If you don't give it at that time or the patient goes home without the PCSK9, the chances of that patient receiving PCSK9 in the OPD in the future drops to less than 5%. So I think use of that. Inclisiran is a good drug. Its the biggest advantage, of course, is that it's given twice a year instead of twice a month. Uh, but again, the problem is inclisiran, in my mind, is that it's fairly recent drug, number one. So we don't have that long a data as we have with evolocumab. That's one issue. Secondly, there's always this anxiety about mRNA-driven drugs and what would be the long-term effects. So one of the side worries was that if you take inclisiran, you get some side effect because it's such a long-acting drug. What can you do about it? Will the side effect remain for long? But we know from studies that the side effects are minimal. However, once you've taken evolocumab, say in the initial ACS period, and then you want to make it easy for you not to take every 2 months, every 2 weeks, then you can shift over to inclisiran and take it every 2. So I think evolocumab and inclisiran have extremely important role to play. In fact, there's a recent study, Dr. Marco, as you know, using inclisiran for primary prevention as a single long-term benefit of these patients. So instead of taking a lot of statins and things like that for a long period of time, just go much earlier towards using inclisiran, especially in patients with extremely high risk or patients who already had some sort of an ASCVD. So I think these drugs are very important. They're going to have a lot of role to play. The problem is they're expensive and they're injectables.
Thank you, sir. Dr. Marco.
Yeah. So my feeling on inclisiran and injectable drugs, yeah, of course there is the cost issue. This is an issue, of course, in Italy is an issue as well. But as you can see in our registry, where we try to give always the right therapy, only one patient out of 4 or 5 discharge after ACS required injectable lipid lowering therapy. So it's a very few number of patients requiring this highly cost therapy. In contrast, this patient, if you give to the patient the injectable drug, you can achieve your goal, and this means that you reduce by 3 times, 4 times the risk of MACE, and the risk of MACE means a cost for the society as well, because if the patient die, of course, it is not a cost, but if the patient will be hospitalized for stroke, for MI, this will be a very high cost for the society. So you have to consider on your balance not just the cost of the drugs, that is of course there is a lot of money there, but the cost of all the treatment. So, and in terms of focusing on the inclisiran specifically, honestly, I do prefer PCSK9, and because of course it's much more easier because the time of injection is much more longer for inclisiran, but there is a sort of heterogeneity in terms of response. So the potency of inclisiran is not so uniform as for PCSK9 inhibitors. So there is some heterogeneity in some patients. So some patients, they respond well, you can reach your LDL goal. Some others not that much. So to me, so far is not the first choice. I will choose I will take inclisiran in case of patient with very like logistic disease issues, patient cannot take every 2 weeks the injection. So in a selected population, I will choose inclisiran.
I have a question for Dr. Marco. Dr. Marco, we know that if you had an acute MI and your LDL is 55, most people will accept that below 55 is reasonably good for every patient. Patients on ezetimibe and rosuvastatin. Now, the studies which have been done with ultravascular and OCT showing regression of plaque, etc., the slide which you showed so beautifully, that is usually be done after PCSK9 when the values have been 20 and 30. So does this plaque regression and all the things that you see on imaging actually happen at 55, or do they have to go down to 30 before these changes happen? So if we give 55, should we be happy with it? And should we then bring it? Is there any study of what happens when you bring it to 55, 60 and not to 30? Would that plaque regression, etc., still happen? Is there any data on that?
So you see, there is a linear regression up to 30. So after below 30, we don't know. But up to 30, we have a linear regression of MACE. And in the ESC guidelines, this is including this evidence because they support this highly extreme cardiovascular risk, which should reach the goal of 40. So guidelines in Europe, they put their very high risk patient with recurrence of events. In this case, if you have more than 2 MI within 2 years, your goal will be no more 55, but will be 40. So because we know that there is still space below 55. We don't know what happened below 30. But so far we can say we don't know. We don't want to go to zero. To me, 20 to 30 will be a nice number. This is my feeling, and this is what the evidence I know.
The Lipid Association of India guidelines has got a group which is called as extremely high risk group, sort of the one with polyvascular disease, multiple episodes, and they suggest LDL. Their recommendation is LDL below 35. They're slightly bit stronger than the European.
Good.
I think
you
that's
see, 30 is fine. Is a fair enough. 30 is a fair enough. And there is still, if you see that the regression line 30, there is some points there, means that there is evidence at 30 milligrams with a nice correlation with the still linear relation. Then maybe there is a spleen of your line, but we don't know yet.
Any other questions, Sharon?
So we have just 2 more questions. This one question is from Dr. Manish, who asks, Indians tend to have high LP little a levels. So in the current scenario where we do not have any available medications for LP little a, what are the upcoming therapies? And in the absence of any agent available currently, what should be our strategy for this patients in mainstream practice? So would you like to take it, Dr. Dalal sir?
Well, we all know that LPA high is a risk factor for coronary artery disease. We know that we don't actually have a drug right now to reduce specifically LPA, but there's a lot of work in pipeline. The best thing to do for people who have high LPA is to keep their LDL as low as possible. So you counteract the high LPA by keeping LDL as low as possible. Statins are not very good drugs for reducing LPA. Ezetimibe reduces LPA, PCSK9 and inclisiran reduce LPA. So if you've got LPA in extremely high range, then definitely add ezetimibe. Try and use PCSK9 inhibitors as well, because LPA can be reduced a small amount with these drugs. Statins themselves are not good for reducing LPA, but the main thing and the easiest thing is to keep the LDL as low as possible to counteract that.
Yeah, so I confirm, I agree, I completely agree. LPA is a marker, is a risk marker, and you have to interpret the value as a risk modification in your patient. So if you have, you will stratify further your patient with this marker. So far, we cannot treat this value. We just consider the value as a marker, as a risk marker.
Thank you, sir. Thank you for that. Last question. Last question is from Dr. Anuj, who asks, who would like to know your final take and clinical tips and tricks to avoid overdiagnosis of statin intolerance in clinical practice. I think this is again Dr. Jamshed Alai, sir. Would you
As
like
I
to?
mentioned, statin intolerance should be differentiated from statin hesitancy. If you've got genuine statin intolerance, that means you've got genuine muscle pains, problems, your CPK is high, then you have to think of some other alternative. And the best alternative is to keep the statin dose as low as possible. Try and use a different statin, maybe pitavastatin, which is known to produce less problems. So that's one option. Second, change to bempedoic acid, which doesn't produce muscle problems. So that's another easy option because bempedoic is available. And use a combination of bempedoic acid and ezetimibe instead of using statins or pushing it. But again, as I mentioned, the most important factor for all adherence problems, not just for lipid adherence treatments, is communication with the doctor and the patient. Tell the patient how important it is to take the medicines, show them how much the risk is of coronary artery disease, show them how lipid lowering will benefit them, and choose the drug which the patient is likely to take. Don't be pushy. Don't say, no, you have to take this whether you like it or not, patient won't take. So follow what the patient wants and try and please the patient, but at the same time, make sure the LDL comes down.
Yeah, completely agree with Dr. Jameshed. So just talk to the patient. As you can see in the fast note data, the problem is that once you discharge your patient, you will lose your contact with the patient. What you have just one bullet on your gun at discharge time point. So try to do your best with the statin and with try. You have a lot of weapons in order to fight the lipid. Do your best at discharge, because later on try to find this to optimize the strategy will be challenge. This is the feeling we have in Europe. So we try to do our best as soon as we can.
I have one question for Dr. Marco. Dr. Marco, Lipid Association of India did a study using statin plus ezetimibe plus bempedoic acid, triple drug therapy, and they found that the levels of LDL were almost as low as when you are giving PCSK9. So, what do you think of this triple therapy? Because if patient doesn't want injectable and doesn't want to bear the cost of the injections, then what do you think of triple therapy as an important part of treatment to get the LDLs down to 30, 40? What do you think of this triple therapy? There's some data from the Lipid Association guidelines, not very big trials, but at least looking at at the LDL levels. We don't, of course, have benefits in terms of clinical events, but we know that if LDL comes down, clinical events come down. Have you usually used this combination of all three drugs?
I'm sorry, you are talking about bempedoic?
Yeah, ezetimibe, statin, and bempedoic acid, all three together.
We used to use bempedoic acid in older patients because we have limited data on PCSK9, and there is a reimbursement also issue in Italy. So there is no reimbursement after 18 years old for PCSK9. So on that side, and then we know that PCS and the bempedoic acid is very powerful in association therapy. So and is effective. So we use especially in older patients where we cannot use the PCSK9 as a first therapy. Sometimes we add PCSK and bempedoic acid to PCSK9 when you have a statin intolerance, of course.
I think other thing I would like to point out, Chame, is that many cardiologists, many physicians start off with the high dose statins, and for some reason, already on the discharge paper, it will be written after 1 month, reduce down the dose. I mean, I don't know why people do that. There's no need to reduce down the dose. If the LDL comes down, very good for the patient. If the LDL comes to 30, even more better for the patient. So, this whole concept that we had in the past of starting at a high dose and then gradually reducing the dose
Yeah,
should be from our mind. I'm sure you see that as well, Professor Marco.
yeah. We need to work on that. Yeah.
Thanks, sir. So any last comment? Anything you would like to add before we close? Mm.
I think only all the speakers I would like to really add, please do pay concentration on the LDL. I still see so many, I mean, I've been practicing for a long time and I still see so many cardiologists and physicians not really paying attention to the LDL. They'll talk of something, I mean, tell them, why don't you give PCSK9? They'll say it's a cost. They don't mind putting 6 stents and doing OCT and cost of the whole procedure, which is far, far more than a few injections of PCSK9. Similarly, with LDL, they'll immediately reduce down the dose of statins with the concern that low LDL is not good or concern that the statins will produce side effects. So doctors themselves have a lot of concern about statins. So you can well imagine that if you have a concern and worry about statins and low LDL, then you're going to display it to the patient as well. I think there's so much data that low LDL is safe, is good for the patient, and yet I see my colleagues not being as aggressive as possible. And we had several of these meetings trying to make them understand the importance of doing it, but still somehow it's still fact that even today, if you dig out patients who had angioplasty done, half of them will not have LDLs anywhere near 45.
Yeah, completely agree. But we need to disseminate the data. There is still a lot of job to do there.
I think we can end now.
Yeah. Thank you so much, Dr. Marco Menuni, sir, and Dr. Jamshed Dalal, sir, for that wonderful session and also for wonderful responses and highlighting key points and during the Q&A discussions. We thank you for your valuable time. We also thank our audience for patient listening. This is actually a festive season in India, Navratri time going on, and many doctors have joined it at this point of time as well. So we thank them, and we are sure that this session would definitely benefit the audience, all the doctors who have joined in, and ultimately help in improving patient outcomes. So we thank you all. And last but not the least, we thank the DocMo team for smooth streaming of this session. So thank you so much. Very good night. Thank you, sirs.
Thank you.
It
Thank
was
you,
truly
Professor.
an honor to have you and learn from you both. Thank you.